We are pleased to present today's program focusing on what we know about the diagnostic journey by reviewing current data from the FTD Disorders Registry, a look at how to diagnose FTD from an expert, and opportunities to learn more about FTD research. Just a few quick announcements, though. First, you should know that we have muted our audience to minimize background noise. AFTD staff are working behind the scenes, so if you encounter a technical issue, let us know directly by writing a message in the Q&A box. Second, time permitting, we will conduct a brief question and answer session at the end of the webinar. Use the same Q&A box to submit a question. If you want to submit a question anonymously, just click the box to the left of the send button. We will try to answer as many as we can. You don't have to wait until the end of the webinar. You can submit your questions at any time. Lastly, this webinar will be recorded and archived for later viewing on AFTD's YouTube page and in the webinar section of our website. Next. Oh, thank you. AFTD's website includes an entire section with FTD-specific information for healthcare professionals. To access this content, visit the URL on the screen. This section includes our entire archive of healthcare professional webinars, as well as a library of the issues of our e-publication, Partners in FTD Care, which details best practices and other information to support your work with families. New issues come out every other month. You can get them delivered by email by clicking the button that says, "Join our mailing list for healthcare professionals." For healthcare professionals watching today's webinar live, we are offering continuing education credit via Rush University. This is part of AFTD's efforts to educate healthcare professionals on FTD and FTD care. Tomorrow, you will receive an email explaining how to apply for your credit. Please note you have 10 days from the date of the activity to complete the evaluation and claim credit. If you don't see this email before contacting us, please check your spam folder. The learning objectives for today's webinar are first, to recognize early symptoms and clinical features that may indicate an FTD disorder and distinguish them from other forms of dementia or psychiatric conditions. Describe the diagnostic workup for suspected FTD, including appropriate use of neuropsychological testing, MRI, and other imaging modalities. Recognize when and how to incorporate genetic counseling and genetic testing into the diagnostic process for FTD disorders. Additionally, we will be sending everyone a follow-up email next week with the recorded webinar link and other related materials. I'll now begin the presentation highlighting data from the FTD Disorders Registry on the FTD diagnostic experience. You might be asking yourself, why is frontotemporal degeneration, or FTD, so difficult to diagnose? The truth is, diagnosing FTD is uniquely challenging for several reasons. First, its symptoms often resemble other disorders. FTD can look like depression, anxiety, or other neurological conditions, which means it's often misdiagnosed early on. Second, FTD usually starts at a younger age than other forms of dementia, often in a person's 40s, 50s, or early 60s. Because of this, many healthcare providers don't even consider dementia as a possibility at first. It's also less common than Alzheimer's, so many clinicians are less familiar with its signs and progression. Another challenge is that memory may still be intact in the early stages. Unlike Alzheimer's, where memory loss is a hallmark symptom, FTD can begin with behavior, personality, or language changes, making it harder to recognize as dementia. On top of that, the symptoms of FTD are highly variable. One person might show impulsive behavior, another might lose the ability to speak, and someone else might seem withdrawn or emotionally flat. There's no one-size-fits-all presentation. And currently, there are no definitive biomarkers, no blood test or scan that can confirm an FTD diagnosis with certainty. Early signs can also be very subtle and are sometimes dismissed by both families and providers as stress, aging, or mood-related issues. Finally, there's still limited awareness of FTD, even among medical professionals. Many clinicians haven't been trained to recognize its early warning signs, and caregivers may not know what to look for. The FTD Disorders Registry plays a vital role in identifying gaps in current care and diagnosis. Since its launch, the registry has been gathering valuable information from individuals diagnosed with FTD, their biological family members, and care partners. The lived experience shared through the platform and surveys provide critical insight that helps shape the path toward future treatments and better care. One key area of focus for the registry is understanding the diagnostic journey. One of the most persistent challenges in FTD care is the delay in reaching an accurate diagnosis. According to current data from our updated registry platform, 68% of participants reported waiting over a year to receive a correct diagnosis. And of those, 44% said they waited 2 to 6 years. These are not minor delays. They represent years of uncertainty, misdirection, and lost time for families who need answers and support. So what's causing these delays? A major factor is misdiagnosis. FTD often presents with symptoms that mimic other conditions, especially in the early stages. The most common misdiagnoses include depression, anxiety, Alzheimer's, and Parkinson's. These overlaps make it easy for even experienced clinicians to mistake FTD for a psychiatric or a more common cognitive disorder. The data underscores the need for better provider education, stronger referral pathways, and greater access to specialists and diagnostic resources. In May 2025, the FTD Disorders Registry posed a quick question to its participants. They asked, what medical procedures, tests, or evaluations did you or your loved one undergo to receive a diagnosis? We had 673 respondents, and their answers revealed some important trends. The most commonly reported evaluations were a neurological examination reported by about 78% of participants, a brain MRI cited by 71%, and a neuropsychological evaluation mentioned by 60%. These are encouraging numbers as they reflect key steps in the diagnostic process for FTD. However, less than half of respondents reported undergoing some other helpful evaluations. Only 45% saw a memory or dementia specialist. Just 43% received a PET scan, 37% had relevant blood tests, and only 33% underwent a CAT scan. This highlights an important gap in the diagnostic pathway. While many are receiving some of the core assessments, too few are being referred to specialists or receiving advanced imaging that can be critical for a timely and accurate FTD diagnosis. Ultimately, this data points to a clear need for more education and awareness among healthcare providers to ensure consistent, comprehensive evaluations are being conducted for those showing signs of FTD. In June, we asked registry participants, what is one thing you would change about the care you received? We had 504 respondents, and their answers were overwhelmingly clear. The most common response, a strong desire for more knowledgeable healthcare providers, clinicians who understand FTD, its symptoms, and how it differs from other conditions. This was followed by several other key themes: easier access to FTD specialists, more guidance on care planning and next steps, and of course, a faster, more accurate diagnosis. These responses give us valuable insight into the patient and caregiver experience. They highlight where the healthcare system is falling short and where we can focus efforts for improvement. When we better understand these reported barriers, it enables healthcare providers to recognize red flags for FTD earlier, refer patients to appropriate specialists, and communicate more effectively. It is now my great privilege to introduce my guest presenters. Dr. David Irwin is the co-director of the Penn Frontotemporal Degeneration Center and leads the Penn Digital Neuropathology Lab at the University of Pennsylvania. With dual training in cognitive neurology and neuropathology, his work integrates brain tissue analysis with imaging and biomarker data to identify therapeutic targets and progression markers for FTD, Lewy body dementia, Alzheimer's, and related disorders. Carrie Millard is the director of the FTD Disorders Registry team and a certified genetic counselor with an MS in genetic counseling from the University of Cincinnati. With over 20 years of clinical research experience across academic, regulatory, and industry settings, she previously led research operations at a genetic testing lab, supporting collaborations, data sharing, and product development. I will note that there will be a single Q&A session directly following our third presenter. Please type your questions into the Q&A box at any time. And now I'd like to introduce Dr. Irwin.
Thank you, Esther, for the wonderful introduction. Good afternoon, everyone. It's my pleasure to contribute to this webinar and review diagnosis and management of FTD. I'm going to share my screen. Okay, so my talk will be from symptom onset to diagnosis, improving the FTD diagnostic journey. These are my disclosures. And to start, to echo the data and presentation by Esther, FTD has an important public health impact. While can be perceived as a less common or rare diagnosis, it really is not. It's more common than as we learn more about the disease, and particularly in the younger age range where it's as common as Alzheimer's disease. And but not exclusively. Up to a quarter of patients with FTD can present over the age of 65. In this age range, there's important personal and societal costs, and when measured, can exceed those types of dementia that occur later in life, because patients are often at the time of diagnosis active in the workforce and may have dependent children, placing extreme caregiver burden on spouses or other loved ones. And as we heard before, diagnostic delays are unfortunately uncommon. At least 50% of patients can see 2 or more physicians and have delays of multiple years of symptoms before a formal diagnosis. We lack FDA-approved therapies and specific diagnostic tests, and for the majority of FTD that is not familial, diagnosis is confirmed only definitively by looking at brain tissue directly with autopsy. This is a schematic that shows an overview of FTD syndromes, and what you see here is the complexity of the biology of FTD. FTD is really a family of neurodegenerative disorders that are characterized by different proteins. And we won't get into the specifics, but you can see that most of the boxes here for different diagnoses that we'll talk about have different shading of colors, red being forms of tau proteins that accumulate in brain cells, or a very different protein called TDP-43. And with the exception of progressive supranuclear palsy or clinical features of ALS, motor neuron disease, these syndromes can vary, meaning multiple pathologies can present with the same syndrome, and including patients who have Alzheimer's disease, plaques and tangles that can present with FTD syndromes. So our goal for this afternoon is to review the diagnosis and management of the behavioral variant of FTD, the most common clinical syndrome of FTD. And then we'll do a brief overview of primary progressive aphasia and related and other FTD syndromes that are part of the spectrum, and then review a hypothetical case to emphasize our learning objectives today. So what's characterized here is a example of an MRI with characteristic knife edge atrophy or a significant frontotemporal atrophy, and the core clinical features of diagnostic criteria for behavioral variant of FTD, which we'll carry through for the slides. But first want to emphasize the main clinical features of the behavioral variant. And This is really defined by early impairments that are social behavior, things that are more difficult to measure and need to be characterized by a careful history and sometimes serial exams to be able to demonstrate and prove that it's a progressive and not episodic. It's also important to establish that the behavioral changes are a departure for someone's baseline personality. So behavior can be context dependent, can be culturally dependent, so it really requires a careful history. And what's important to note is that often early in the disease, cognitive impairment may be very minimal and imaging may be modest compared to this example image here. So a careful history is important. And behavioral features are very heterogeneous. Not every patient has every constellation of symptoms depicted here in our symptom box. So a key aspect of the evaluation of patients with suspected FTD is a reliable informant or informants who have consistent time spent with the patient to have a really detailed history and establish these features of a social disorder that characterizes FTD. I highlight here and have a QC code to the AFTD has designed and developed a diagnostic checklist, which can be extremely helpful in the diagnosis of FTD, which gives both the clinician and family members the ability to document and work through the core clinical features of FTD to help establish this progressive social disorder. And walking through the specific features of the social disorder, first is the behavioral disinhibition. This can come in many forms, such as approaching strangers, saying rude or inappropriate comments that are non-characteristic from a patient's personality, impulsive decisions that aren't characteristic of someone prior to the onset of symptoms. And these are very active symptoms, but also there are other symptoms that are less active, but could cause significant difficulties, such as responding to solicitors and giving out personal information. So important in terms of detecting and helping manage symptoms. There can be apathy or less motivation, less interest in previous hobbies. At times, this can also affect hygiene, requiring reminders for aspects of self-care. Loss of empathy can come in forms of loss of emotional warmth, less social interest, emotional responsiveness to spouse and family members. These things can be difficult to elicit and differentiate from psychiatric disorder, again, which requires a detailed social history from a reliable informant. There could be ritualistic or compulsive repetitive behaviors. This could include complex behaviors such as being preoccupied with an activity that's difficult to interrupt, such as counting steps, reading signs aloud while driving in the car, cutting out pieces of newspaper and collecting them, for example, or more simple motor rituals like tapping, rubbing, whistling, things that are very repetitive. And hyperorality, engaging in increased intake of food in a compulsive manner, craving specific types of food, particularly carbohydrates or high-fat foods, and this can result in weight gain and rapid time course and also risk of a metabolic syndrome. In terms of the cognitive impairment, the profile of the types of cognitive impairment we see with FTD tends to be an executive dysfunction or frontal lobe signs. Symptomatically, this could be reported to you as a clinician as difficulty in planning a trip, leaving tasks undone, having difficulty planning and organizing aspects of daily living. In terms of neuropsychological testing, the typical profile is a disproportionate difficulty in tasks that include set shifting, mental search strategy and flexibility, and working memory, with examples listed here. Other aspects of cognition or cognitive domains, such as episodic memory and visual perceptual function, are relatively spared, and this helps us differentiate with classic amnestic forms of Alzheimer's disease. It is important to note that there are a subset of patients that may fulfill criteria and have FTD that could have episodic memory. So if we do see difficulty with remembering recent events and problems with list learning tests and visual memory, that's not necessarily exclusionary. So again, to establish the diagnosis, we need a reliable informant in establishing evidence of a progressive social disorder that's a departure from someone's baseline personality. An important part of the workup is screening lab work to help exclude reversible mimics of neurodegenerative disease. In particular, executive dysfunction and apathy are somewhat nonspecific in isolation. So outside of the other clinical features, these type of cognitive impairment and/or behavior can be seen in psychiatric disease and in metabolic syndrome. So looking for common etiologies like hypothyroidism, vitamin B12 deficiency, for example, are important. Neuroimaging is a key part of the clinical criteria for FTD. It's important to exclude non-neurodegenerative mimics, such as slow-growing mass in the frontal lobe that could mimic FTD, and also support the diagnosis by showing frontotemporal atrophy, as illustrated here. Functional imaging with FTG PET can be also helpful and supportive for the diagnosis by looking at the patterns of hypometabolism. If structural MRI is ambiguous, looking at the patterns of hypometabolism can help differentiate from Alzheimer's disease or dementia with Lewy bodies, which can present with executive and sometimes neuropsychiatric features that can be similar to FTD. As Esther mentioned, we lack the specific imaging or biofluid tests for the pathologies associated with FTD. So it's important to establish these criteria. And also, genetic counseling is a core aspect of FTD care because the risk for familial disease is higher compared to other neurodegenerative diseases such as Alzheimer's disease or Parkinson's disease. This slide here helps illustrate that about 40% of patients with FTD have a positive family history of either FTD or motor neuron disease or ALS. And in some genetic forms of FTD can have an increased risk for both. And about 20% of all patients with FTD can have a pathogenic mutation or a causal variant that could be inherited in the next generation, and important to detect to help with the precision of diagnosis in terms of a biological diagnosis, and also that can help inform families at risk. This is a brief summary of a report that we did several years ago using structured pedigree analysis, avoiding all the details here, but just by able to classify the number of first and second degree relatives with a dementia or with a more specific FTD or ALS diagnosis, we can classify risk, and those patients with higher levels of family history at higher rate of having a pathogenic variant. So genetic testing is a very personal decision. Counseling and access to genetic counseling to help patients and families make the best decision is really important. So as we apply our FTD criteria, possible behavioral variant FTD requires 3 or more of the 6 categories that we reviewed and are listed here on the box here. Probable bvFTD is an increased level of certainty, and that's when we have evidence of functional decline to help establish that it's progressive, and also imaging as illustrated here that's supportive of the diagnosis and helps differentiate from other neurodegenerative disorders or psychiatric disease. And then definitive behavioral variant FTD, as mentioned before, to be completely definitive would require either autopsy confirmation of the specific brain pathologies listed here, or in the subset of patients who have familial disease, detection of a pathogenic variant. Exclusionary features, when to think it's not FTD is important. If there is a pre-existing psychiatric disease, that can be very hard to tease apart from or to differentiate from the emergence of a new social disorder, and looking for other explanations, particularly if it's difficult to establish progression and/or imaging markers that are supportive. With the increased use of Alzheimer's disease clinical tests, both in spinal fluid, plasma, and PET imaging, important to note that AD copathology, so most of us with increased age can accumulate small amounts or moderate amounts of plaques and tangles that can affect those tests. So Alzheimer's tests don't rule out FTD as the pathologic cause. And as we learn more in research will help us further refine, and we need the FTD specific biomarkers to help us in that. So shifting to management, non-pharmacological interventions are still the first line and can make a large impact on patients and families. A structured environment is very important. Avoiding downtime, unstructured time can precipitate anxiety and problematic behaviors. And as a clinician, it's important at every visit to do a targeted symptom approach to review with patients and families aspects of mood, behavior, sleep, language, and motor functioning so that a customized supportive care plan and symptomatic therapies, if indicated, can be prescribed to help with care for patients with FTD. Also, going over for caregivers and family members, de-escalation strategies, how to redirect behaviors is another important first-line management. We lack FDA-approved therapies, but using a targeted approach and for symptomatic therapies, for mood and behavior, a lowest effective dose approach can be effective. So careful titration and ongoing discussion with families and patients to help find the optimal dose and avoiding potential side effects is important. And over the course of disease, early on, active disinhibited behaviors may be replaced with more apathetic behavior, and medicines can be revisited at every evaluation to determine if down titration over time is appropriate to, again, get the lowest effective dose approach. And we lack data to guide decisions, so which is important, and the emergence of clinical trials for FTD is very important. So moving on with a brief overview of some of the related symptoms for familiarity of other forms of FTD. Primary progressive aphasia is also a clinical form of FTD. To help differentiate from other diseases, it's characterized by a prominent and early impairment of language that's progressive and not caused by other etiologies such as stroke or brain tumor. The language exam involves evaluation of spontaneous speech as well as aspects of confrontation naming, grammatical expression and comprehension, and as well as repetition. And we'll go through some brief examples. One main form of primary progressive aphasia is the semantic variant. Illustrated here is left anterior temporal lobe disease, and most patients have a form of TDP-43 microscopically. This is similar to a Wernicke's aphasia in terms of comprehension being the main feature of the aphasia, but in distinction, it's for single words and objects rather than usually sentence level comprehension as seen as in a Wernicke's aphasia, and repetition is spared. There can be something called surface dyslexia, where orthographically irregular words like choir and yacht are read phonetically, such as chore or yacked. This is on one end of the spectrum of primary progressive aphasia. The other is the non-fluent. Here's just to illustrate an example of the speech. This is a speech transcription from a patient who received the cookie theft picture. And what's illustrated here is that the content of the story is lacking because there's a lack of use of nouns from semantic loss. And the rate of speech is within the normal range. Moving on to the non-fluent or agrammatic variant of primary progressive aphasia, these patients have disease that's more localized in the left inferior frontal lobe, as illustrated here, and are about 70% likely to have an underlying form of tau. Similar to a Broca's aphasia, speech is usually slow, non-fluent, have grammatical errors. Usually repetition is preserved, as is comprehension in comparison to the semantic variant. This is an example of a speech sample with the same cookie theft stimulus in a patient who had the non-fluent variant. What's being summarized here is grammatical errors and motor speech impairments that are color-coded. And important to note, normal human speech is about 140 words per minute. Non-fluent primary progressive aphasia patients is usually about a third of that, in the range of 40. And this is from the work of the late Dr. Murray Grossman, who we have this sample from. Finally, just to review motor forms of FTD and overlap of motor features, ALS can emerge in some patients with FTD. This is an illustration of work that we've done looking at brain tissue and illustrating that TDP-43, the protein of ALS, and about half patients with FTD, when it extends and involves areas beyond the motor system in ALS patients, correlates well with the emergence of FTD. So about 50% of ALS patients have some element of cognitive impairment, and this can overlap with overt behavioral variant FTD or primary progressive aphasia. Conversely, upper motor neuron signs of spasticity and increased reflexes, and lower motor neuron signs of muscle wasting, weakness, and fasciculations can emerge in patients with FTD as well. So a good motor exam is also an important part of the evaluation for FTD patients. Cortical basal syndrome is a syndrome that's characterized as usually highly asymmetric, as other forms of FTD like primary progressive aphasia I showed you before, and it can overlap with primary progressive aphasia. What you're seeing here is a patient who has disproportionate frontoparietal disease more on the right than the left. And the clinical features range from varying amounts of Parkinsonism, including dystonia or a fixed posture of a limb, myoclonus, and rigidity, as well as cognitive impairment, which can range from executive impairments, but also visual spatial impairments that we typically think of Alzheimer's disease, and apraxia. This is in the setting of preserved strength and sensation, difficulty articulating fine movements. This could have significant functional impairment as it affects things like using utensils, buttons, and shoelaces, and in some cases can cause alien limb phenomenon where a limb can feel foreign or different to a patient. Occupational therapy can be very effective for patients who have apraxia, and also physical therapy to help with the motor features. So as an asymmetric frontoparietal disease, often, if you can imagine on the left hemisphere, this can involve areas that we discussed with the non-fluent form of primary progressive aphasia, and indeed we can see overlap with the non-fluent variant or non-fluent aphasia symptoms, as well as behavioral symptoms. And the pathology is heterogeneous. About 60% of patients have a form of tau. Up to 30% can have an atypical form of Alzheimer's disease, plaques and tangles, that for reasons are unclear, present in a more focal and asymmetric manner. And a minority of patients can have TDP-43 as the cause of the syndrome. So this syndrome in particular can be caused by many different FTD and AD pathologies. In contrast, progressive supranuclear palsy, or classic Richardson syndrome, is characterized by postural instability that can be in the clinical history. Early falls, a key feature. Oculomotor dysfunction, particularly incomplete and slowed vertical saccades. An ancillary feature could be photosensitivity, as well as reduced blink or eyelid apraxia, including blepharospasm or difficulty with eye opening. And Parkinsonism that's more axial, particularly axial rigidity and retrocalis. And the cognitive impairment is usually present early compared to Parkinson's disease and involves, again, frontal and executive type symptoms that we talked about with behavioral variant. Similarly, it can overlap with non-fluent primary progressive aphasia and behavioral variant FTD. And when these core clinical criteria are met, in contrast to other forms of FTD, the pathology is highly likely tau. What you're seeing here is a photomicrograph of tau pathology in a brain of a patient with PSP. And we can see this syndrome have a high correspondence as color-coded here as being PSP tau based on these clinical symptoms, and thus tau-targeted clinical trials are focused on PSP patients, but we also know that the same PSP tau in different patients can present sometimes with cortical basal syndrome, sometimes with non-fluent progressive aphasia, and sometimes with the behavioral variant. So important to highlight, the most recent PSP diagnostic criteria, which was revised in 2017, has different levels of certainty for each core feature of progressive supranuclear palsy. And there's more details that, in interest of time, that I won't go through, but the idea is that different constellation of these levels of certainty allow the criteria to help us diagnose early stages of PSP, to help if we see subtle features of oculomotility disorder and postural instability, for example, in the setting of behavioral variant FTD, that can be a sign that underlying PSP and tauopathy is the cause. So this helps us with epidemiology and increased diagnostic accuracy, and is an important aspect to be aware of in cognitive clinics, our emergence of motor and oculomotility dysfunction. So another theme or important aspect of FTD care is multidisciplinary care. And for patients who have shared motor and cognitive features, close collaboration with colleagues across neurologic subspecialties are also important. So finally, I'd like to end with a hypothetical case that helps illustrate the key learning objectives for today's session. I'll read through briefly and summarize the case. This was a patient who was 56 years old. The chief complaint was supplied from the patient's spouse rather than the patient themselves, and it was characterized as a social disorder. The personality has changed, and it had been about a year. There was a ceremony that the patient stood up in front of a crowd and went to speak to the speaker, which caused somewhat disruption of the event because socially that interaction wasn't appropriate in that time, although it was well-intentioned. And when the patient's family had discussed that that was disruptive to the event, the insight into that wasn't clear and brought them to medical attention. There are other aspects of social interaction or reduced social judgment, including a withdrawal, not contacting family and friends, not initiating social events like before, as well as approaching more active symptoms of approaching children and people on the street and pets. And while being friendly is important, there was a certain element of invading people's personal space while waiting online at a store, for example. And when social cues of that this was by people in public not appropriate, and an ability to react to that and act appropriate, which was concerning to the patient's family. And there was also poor judgment, buying excessive amounts of things online that were uncharacteristic or new, and lack of empathy, and particularly a holiday where normally patient's baseline personality would be very warm and gracious, essentially taking gifts from family members and showing and commenting overtly in what was perceived as a not sensitive way of not liking the gift. Finally, there was also elements of change in diet, being preoccupied with high carbohydrate meals like pasta, and collecting sweets and keeping them in a separate room. And that resulted in a rapid weight gain of about 20 pounds over the course of 2 to 3 months. When discussing this with the family and the patient, The patient had limited insight, saying superficially, I should listen to my family, but not really showing the emotional depth of understanding the concern and of the situation. There's aspects of functional decline, in addition to the social changes outlined here, difficulty with executive functioning and keeping up with job responsibility and needing assistance for the finances. Finally, in terms of the history of present illness, a careful family history revealed that the mother was diagnosed with Alzheimer's disease in her 60s, and there was a maternal grandfather that had odd behavior and had a cognitive decline of unclear etiology that had resulted in institutionalization around the same age. So this would be an autosomal dominant pattern of an unclear cognitive and/or behavioral disorder. In terms of the cognitive exam, in terms of bedside examination that captures elements of neuropsychological testing, in terms of speech was fluent, but there was an affect that was somewhat childlike. Patient was easily distractible, and if not engaged in direct conversation or a task in cognitive testing, would be drawn to look out the window or not pay attention, which was important. In terms of memory testing, using a list learning task of 6 words, the patient could recall 4 out of the 6 after a delay and had good crisp recognition of the remaining 2 with cues, showing a minimal amnestic deficit or memory problem. Here is an example of a modified Ray Austereth figure showing large recapitulation of the figure or visual readout of memory, which is similarly largely intact, but was more prominent was difficulty with executive functioning tasks such as oral trails and digits backwards. Other specific aspects of language exam, including naming and single word and object knowledge, visual spatial functioning, as you could see in this constructional task, and the copy and praxis calculations were all within normal limits. The global mini mental score was 29 out of 30, which would be normal despite these difficulties, and the elemental exam was unrevealing. These are example MRIs of a patient with FTD showing asymmetric disease, in this case in the right hemisphere, in both dorsolateral prefrontal cortex, as well as medial and ventral frontal cortices, as well as anterior temporal lobe. And these help us establish criteria for probable FTD. Cerebral spinal fluid analysis for cells, protein, glucose was normal. Alzheimer's disease related markers here were within normal limits. Labs for common reversible etiologies and plasma p-tau217 within normal limits. After a detailed discussion with the patient and family as part of the initial diagnosis and concern for suspected or possible behavioral variant FTD before getting the imaging, and the family history discussion of genetic counseling was discussed, and the family and patient decided to pursue genetic counseling, ultimately genetic testing, and in this case, finding a pathogenic null variant in the progranulin gene. So to review our diagnostic criteria, this patient showed a progressive change in behavior and cognition. There was early behavioral disinhibition, which was a key aspect of the clinical presentation. There was a loss of sympathy and empathy, with the example from the family of responses to at the holidays and in terms of initiating social interactions. There was complex compulsive behavior, changes in diet, and the neuropsychological profile largely in the executive domain. So we have 3 or more of these core criteria, meaning probable criteria for the behavioral variant of FTD. There was significant functional decline as the patient eventually needed help with complex activities of daily living, and there were imaging results supportive of FTD as shown in the MRI. With the genetic counseling and ultimately testing, presence of a pathogenic mutation gives us a biological diagnosis of FTD and a definite diagnosis of FTD. In terms of the management of this patient, social work support and counseling from the clinician, as well as from social work with the supports of ways to implement a structured environment, having a visiting companion to come several hours a week, as well as a day center where social interaction and goal-directed activities can be pursued, having activities around those arrangements. So those give caregiver respite, but also the caregiver then can implement other activities such as watering the plants, taking care of pets, listening to music, engaging in crafts. These types of structured activity throughout the day help reduce the precipitation of behavior. Also being vigilant for risks because of the difficulty with perspective taking, access to the internet and finances to help prevent exploitation, and redirectional strategies for problematic and repetitive behaviors. Driver's evaluation also important to help determine safety for driving, and symptomatic management. We know that FTD patients have a reduction in serotonin in the brain from postmortem studies. So careful titration, for example, of a low-dose serotonin reuptake inhibitor can help reduce repetitive behaviors. And the genetic counseling here helped identify, after counseling, a pathogenic variant, which helps other family members with predictive testing and family planning, as well as potential clinical trial opportunities. So to end and summarize, the clinical criteria for the behavioral variant of FTD are important for the early diagnosis, differentiation from both non-neurodegenerative diseases like, I have an echo on my machine, I'm sorry. I think it's gone now. So I'll finish up just to say with both non-neurodegenerative disorders, such as psychiatric disease, as well as Alzheimer's, Lewy body, and other neurodegenerative disorders, positive amyloid testing doesn't exclude a diagnosis of FTD. Because of the higher rates of familial disease, genetic counseling is important, and cognitive impairment may be minimal early stages of disease. So having a comprehensive evaluation of social history and a reliable informant is important. And supportive care for the patient and caregiver is critical to avoid the morbidity associated with social impairments. And finally, at each and every visit, careful assessment of symptoms, targeting with pharmacologic therapy as indicated, the lowest effective doses, and revisiting that at subsequent visits. So thank you very much. I look forward to the remainder of the program.
Thank you so much, Dr. Irwin, for that very informative presentation. Dr. Irwin will return in just a few minutes for our Q&A portion. First, however, let's hear from Carrie Miller, Director of the FTD Disorders Registry.
Thank you, Esther and Dr. Irwin, for sharing your insights and expertise. All of the insights Esther shared today come directly from the FTD Disorders Registry, which is a global direct-to-participant research resource, which was co-founded by the Association for Frontotemporal Degeneration, the Bluefield Project, with support from the Rainwater Charitable Foundation and our All FTD partnership. The registry is powered by generous participation of people living with and impacted by FTD disorders. The registry exists to accelerate research for the full spectrum of FTD disorders by providing resources that empower people to participate in research, amplify the voice of those with lived experience, and share de-identified data collected through the registry with researchers in the field. Harnessing the data and tools the registry offers can help improve diagnosis, treatment, and research outcomes. But it's only as strong as the community behind it. And that's why we need the help of providers to connect more individuals and families to the registry so we can build the most complete and accurate picture of the lived experience of FTD disorders possible. While the while the registry's new platform does allow participants to link their medical records, the registry is unique because it doesn't just collect clinical or medical data, it captures the real-world lived experience. Participants share their symptom histories, their diagnostic journey, and updates over time, and this creates a richer, more detailed data set than medical records alone. By analyzing this information, we can generate data-driven insights that help clinicians better recognize and manage FTD while guiding researchers in designing and refining clinical trials that address the real-world needs of this community. All the registry data we share with researchers is de-identified to protect privacy, creating a trusted bridge between personal experience and clinical understanding, one that allows researchers and clinicians to see the full picture and not just isolated moments in time. Next slide, please. When we connect lived experience to research, important things happen. First, patterns emerge, such as clusters of early symptoms, timelines to diagnosis, or possible risk factors, and this can improve how FTD is recognized in the clinic. Second, families gain direct access to research opportunities, often for the very first time. Many can even participate in studies from home, removing some of the common barriers like travel or cost. And for researchers, this means faster recruitment and more diverse representative data. Next slide. The registry is already a trusted resource for both academic and industry researchers. It's supported a wide range of studies, from observational projects tracking symptom progression to interventional trials testing new treatments. Through the researcher portal, qualified investigators can securely access de-identified participant data to explore trends, identify potential study cohorts, and develop new research questions. This means that every participant's contribution has the potential to inform multiple studies over time, magnifying its impact. Next slide, please. You as providers are a critical link in this process. You're often the first trusted source of information for patients and families after an FTD diagnosis or when symptoms are under investigation. Here's how you can help. You can encourage individuals and care partners to enroll. It's free, secure, and it only takes a few minutes to sign up. You can share the registry as a simple, immediate way for patients to contribute to FTD research. And then you can also look for referral opportunities, especially when a diagnosis is suspected or new, when there's a family history, or when you're discussing potential clinical trials. Every referral strengthens the registry, accelerates research, and ultimately improves the accuracy and speed of FTD diagnosis. Next slide. So referring a patient to the registry is a simple step that can lead to powerful insights and accelerate progress toward earlier diagnosis and better care. As a healthcare provider, you can play two important roles. First, by encouraging individuals and care partners to enroll in the registry. And second, by joining the registry yourself. When providers register, they can stay informed about new research opportunities, emerging findings, and studies that may be a good fit for their patients. Numbers have power. Every person who joins the registry sends a clear signal to researchers and industry alike that we have an engaged, ready to participate community, one that is committed to pushing FTD research forward. The more voices we have, the faster we can move toward a better understanding, earlier diagnosis, and better care. I want to thank you all for joining us today. I'd now like to welcome back Esther and Dr. Irwin to continue the conversation.
Thank you, Carrie. Let's take some audience questions in the time we have remaining. If you haven't submitted a question yet, use the Q&A box and we'll get to as many questions as we can. To post anonymously, click the box to the left of the send button. All right, Dr. Irwin, one of the questions we have, which I think is a common one we have, is how do you get information from a care partner or informant at your clinic, or what are best practices in trying to get that information while respecting the autonomy of the person diagnosed?
Yeah, that's a great question. I think, being clear in the beginning of an evaluation with the patient, is it okay if I, ask your loved ones about what you've been experiencing as well as you? That helps me understand exactly, why you're here and helps me help you the most. And depending on patient and family preferences, sometimes that means splitting up to help make sure that all folks, both the patients and caregivers and family, can feel comfortable with that. So having a empathetic approach and promoting autonomy to the patient and explaining why is usually an effective, approach to get that careful history.
Yes, thank you. I think that's one of the hard things that families face often, and clinicians, in trying to get the necessary information to see what's really happening and getting a good picture of the changes that are occurring in the person. So thank you for that. We have another person who's asking, and Carrie or Dr. Irwin, either of you can answer this one. They're asking about genetic testing, and is it required for diagnosis if a patient checks at least 3 boxes on the checklist? Or, for example, if they know they have at least 2 deceased siblings who were diagnosed with FTD.
But yeah, for genetic testing isn't required for a diagnosis. You can establish a diagnosis of FTD using those criteria. It can help identify if there is a variant present, could be as a biological definitive diagnosis. Carrie, do you want to expand on that further?
No, that was my answer as well, but just saying that also by doing that genetic test, if it does come back positive, it provides information for the family as to how to move forward, getting counseling for additional family members.
And I think the underlying thing there is it's never required, but we always want to offer genetic counseling and provide education and support in the process. Another big question we had came to, you talked about tau a lot in your presentation and TDP-43. Can you explain a little bit what they are?
Yeah, I throw those terms around, and sometimes, as being interested in pathology, these are the causes of the disease. Current PET tracers that are available for Alzheimer's, unfortunately, aren't able to visualize the type of tau that's in about half of patients with FTD. The other have TDP-43. These are proteins we all have in our brain, and for reasons that aren't entirely understood, start to aggregate in brain cells and in different types of brain cells. So the tau of FTD tau or FTLD tau is formed in a different way than Alzheimer's disease and doesn't have the plaque part of Alzheimer's. And TDP-43 is a different protein that's found in the nucleus of brain cells and becomes trapped in the cell body. And we need tests that can start to visualize these on imaging and or detect in blood and spinal fluid to help us be more precise with the diagnosis.
Another big question we're getting is about anosognosia and lack of insight, and how that kind of affects getting an accurate diagnosis. Do you have any insight from your clinic and how you guys handle when anosognosia is present and you're trying to do a diagnosis?
Yeah, it's not part of the formal criteria. It can be helpful in some patients, but it's important to recognize that not all patients, patients have varying levels of insight. And if you are seeing someone who is able to express concern for their own behavior, it isn't exclusionary. So, it's uh, in the example hypothetical case that I show, there was some limited insight, but the emotional depth wasn't there. So that it's a hard thing to measure insight, and it's important, I think, with patients with FTD to make sure that we don't assume that they don't have insight and to always respect their autonomy when discussing, these sensitive topics of behavior and personality change.
Carrie, this question is for you. What subtypes of FTD or who can participate in the FTD Disorders Registry?
So really, anybody with an interest in any FTD research, and it can be bvFTD, PSP, CBD, it can be PPA, all subtypes are welcome to join the FTD Disorders Registry. And even if you have a suspected diagnosis and you want to gather more information and look at research opportunities, we welcome you to come in. And it's not only people who are impacted, but also researchers and healthcare providers are welcome to join the registry to have access to a personalized dashboard that allows you to browse topics of interest.
Thank you, Carrie. So that about wraps up our Q&A session. Thanks again to Carrie and Dr. Irwin. Unfortunately, we cannot address everyone's questions here today, but the AFTD helpline is another great way to get in touch with the resources you need. AFTD wants families and healthcare professionals to know about FTD research and research opportunities. The registry is a powerful tool in the movement to discover treatments and a cure for FTD. Anyone with firsthand experience with FTD, from persons diagnosed with FTD to their caregivers, family members, healthcare providers, and friends, are encouraged to join the registry to stay informed about opportunities to participate in research. Visit ftdregistry.org to learn more. This concludes our webinar. Please let us know if you have any comments or questions about today's presentation. If you have any further questions about FTD diagnosis or the FTD Disorders Registry, you can contact the AFTD helpline using the information on your screen. Look for an email tomorrow containing instructions for submitting your CEC credit. Thank you.